Hi, everyone. My name's Dr. Elissa Adame, and I am here to share with you some things that we've been up to with a project called the Brave Spaces. I am part of a bigger team of Dr. Cynthia Stonnington, who will share with you our big why in a moment. Dr. Hartmark-Hill, who's going to talk to you about stories and the importance of stories, and also Keith Jones, who's going to tell us about a specific, very intriguing case study from his own work. So I will hand it over to Dr. Stonnington.
Thank you. Thank you. And Elissa will also end us up with some exciting research that we've been doing. So I'm, as Cynthia Stonnington. I am a professor of psychiatry and the associate medical director for the Office of Joy and Wellbeing at Mayo Clinic in Arizona. And I'm also on the steering council for the Wellbeing Collaborative. And as you can see here from the three main strategies for building sustainable health ecosystems, one of the tactics that we are really focusing in right now on that we want to share with you about is brave spaces. And brave spaces will definitely be something we think will help with building inclusive and high-performing teams, but also we think it will very much touch developing leaders and prioritizing well-being. So what is this all about? Well, you know, as Flo mentioned in the beginning, even as, even just having a Zoom meeting, which now most of our meetings are instead of in person, people don't even turn on their cameras half the time, right? But we are seeing, and this isn't really new in terms of the issues that we're seeing, because if you look at staff surveys, not just from Mayo Clinic, but really from most institutions, you'll see people will often say they don't feel free to speak up or say what's on their mind, really. And they don't have that sense of the belonging that we say when we sort of get into a meeting and we say, hey, this is a safe space, go ahead and speak up. You know, you can say it, but really, do you mean it? And what are the behaviors that really will enable people to be able to really say what's going on? Now, why is this important? Well, of course, we know in our general community today, we are seeing less and less tolerance of beliefs of people who people who have different beliefs than your own, and we're seeing among those same people that they only are looking for confirming stories or confirming evidence for what they believe. We know in science, very important in order to innovate, in order to really do the best for our patients, we need to be looking for disconfirming evidence. We need to look for what is it that we are not seeing? What is it that really is going to disprove my hypothesis, right? If people are not willing to speak up and share, then we're not going to be able to really innovate very well, and we're not going to be able to save patient lives because we are missing something, because somebody who is on a, maybe at a lower level of hierarchy doesn't feel free to share what is really going on. And we're going to see a whole group of people who feel like they're not being listened to and heard, and they may actually quietly leave the healthcare force because they feel marginalized. So we really are interested in trying to figure out and dig deep and find out what are the actual behaviors that we can teach, not just the leaders, but teams, to really have these really important conversations and to be able to really speak freely. I mean, not only speak freely, but to actually celebrate it when somebody does do that and not feel like they are marginalized for it. So we do know a lot about psychological safety, and this is part of it. So, but it's not the end of it. But Timothy Clark, if you don't know his work, he's written a lovely book on the 4 stages of psychological safety. And our colleagues at Mayo Clinic have taken that work and put it into a lovely diagram that you see here. And at the very bottom of that pyramid is inclusion, right? That's the base of it, that we need to have everyone feeling a sense of belonging, acceptance, respect from the team. But yet, what are those behaviors that allow people? How do you invite feedback? How do you respond to feedback? What are the things that you're saying to people? What are you doing? How are you having these conversations? Are you doing it all asynchronously on email? Are you having hallway conversations? What is it that's happening that's really enabling or actually making people feel like we don't really encourage people to actually be vulnerable, or are we actually doing things that will allow for people to feel like they can challenge? So at the bottom is inclusion. Then the next is really being able to make a mistake, and how are we responding to those mistakes? Do we punish, or do we really use them as growth opportunities? Do we feel like we're valuing people when they contribute something? And are we valuing people when they actually challenge what we're saying? So these are the things that we're so interested in learning about. And we think that in order to do that, we want to start with, we think one strategy is actually storytelling, and it's also creating a space where people can destigmatize vulnerability. So I'm going to hand it over to Keith.
Great, thank you. Thank you, Cynthia. I really appreciate it. And my co-presenters, thank you for having me here. My name is Keith Jones, and I support staff wellbeing at Mayo Clinic in the Office of Joy and Wellbeing with Dr. Stonnington. So I'm going to share a case study. I guess you can tell who it's going to be about. It's going to be about me. And so the part of one of this case study is being out of touch. And here I had an inaccurate self-assessment about how I was showing up to other people. And I had a couple of things that I'm clear about is I had really good intentions. I think most people do. I certainly did. But I assume my definition of success, that how I defined it, was true for everyone. It was a shocker when people had other ideas about what was successful to them. And there was a barrier to this, and the barrier is that I didn't, like Dr. Stonnington talked about, I didn't have a lot of capacity for inclusion or to welcome different voices or opinions or ideas about how to move forward. I thought that my idea about how to move forward was the correct way. I see a lot of people in the audience from Mayo Clinic that I work with, and they don't know that Keith, and that's a good thing because I probably wouldn't be at Mayo. That's Keith 1.0. Today you guys are seeing Keith 2.0. I would have burned down all those relationships. And so I had a wake-up call, and the wake-up call I had was in the form of a dear friend. My history at Mayo Clinic, I started as a volunteer, but I'm originally from Tennessee. I moved out here and I served the Marine Corps for 4 years. That's what brought me out to Arizona. And I came kicking and screaming, but the Marine Corps didn't care. So I came out here, I went on to ASU, did financial planning, did those things. But along the way, I started a well-being company here in Arizona. And so I would attract a lot of type A people. They were just like me. Pretty much tone didn't matter, what you said didn't matter. Can you help me accomplish my goal? And they would put up with pretty much everything that I had to say and my definition of what I thought we should be doing in these well-being workshops that included physical exercise, nutrition, as well as personal development. And what was interesting is we continued to grow and word of mouth spread and more people were coming. Some of their friends were not type A people. So the type A people would come to the workshops and they were appalled by the way that I yelled at them. I mean, I was like, just do it. And they would be upset or want to have a private conversation with me. And I was like, no, we're here to work. And so one day, a dear friend of mine named Dawn pulled me aside and she said, hey, Keith, can I talk to you about something? I said, sure. I guess I happened to get 8 hours of sleep that night, so I was in a good mood. And so she started talking to me and she said, hey, listen, there's something I want to ask you. Is it okay? I was like, sure. She's like, well, when we meet every Saturday morning at the track to work out, we're there for an hour and a half and no one can go use the bathroom. I'm like, so what are you saying? Can we go use the bathroom? I was like, yeah, sure. I said, how long you been wanting to ask me that? She said, a year and a half. I'm like, a year and a half? I mean, and I was shocked, and it was a wake-up call to me that people, with something as trivial as the bathroom, they felt like they couldn't ask me to do that. And so that was I was like, our tagline at the time was inspiring you to inspire others. And it was clear to me that that was not what was happening. I wasn't creating a space for this to occur. And so I cared so much about the success of this well-being company and people reaching their goals beyond what I thought their goals should be. But I cared so much about it that I was willing to change. Like, that was a leverage for me. Before, if someone else said, hey, to make more money or to grow the community, that wasn't that important to me. But knowing that I was going to try to make a difference in helping people achieve their goals and building community, that mattered to me. And so I had to come up with a way for people to overcome my reflexive problematic behavior. And so I came up with a list of things of how I automatically react when people have something to say that I don't want to hear, or when people give me feedback. And by the way, Keith 1.0's definition of feedback, of feedback was, Keith, you're doing a great job. Anything, Keith, but we got a problem. And so I wasn't really open to feedback, although I said I was. And so I came up with this idea in which I took people through an exercise in which they would list all the ways that they thought the person that they were going to have a conversation with might react. And then it was a way of disarming them so they wouldn't react that way, so they could actually hear the conversation. So because I was trying to play a big game and I knew I needed to change, I gave people like this code to get beyond Keith 1.0 so that we can really build connection, create a space of vulnerability where people could really connect. And so I'll just read to you what I gave to people back then. And boy, they took advantage of it. So here it starts out. Keith, I need to talk to you. It's an important conversation. Before I go on, I would like to share a few fears I have with you. My first fear in talking to you, and what almost stopped me, is that you will interrupt me and not allow me to finish. That's for sure. My second fear is that you will become defensive. My third fear is that you will minimize what I share or rationalize your thinking and behavior. And my fourth fear is that you will punish me for bringing this up by withdrawing from our relationship as colleagues and or as friends. So in the face of these fears, I'm going to continue because our mission and our relationship as colleagues is important to me. And so by doing that, every time they mention something that they took away about being defensive, closing off, and I wasn't an argumentative person, I didn't yell, what I would do is I would withdraw from the relationship without them even knowing it. And there would be this distance and my heart would close to people. And so by doing that, that's not the way I responded. I responded openly. And then we started to co-create whatever it was. By the way, they did start using the bathroom whenever they needed to go. They didn't have to ask me, so that did happen. But it was really important. So if you are a parent, if we try it on this way, the way that it might look is that you tell your child that no matter what happens in your life, you can always come to me. But let's say the child doesn't feel that way. That part of your reflexive problematic behavior is that you immediately start saying, how could you let this happen? I can't believe this. Like, are you serious? You know, and you started to go right to punishment or all the things that raised you better than this. What is the likelihood of the child being open to you? Probably unlikely. But if the child starts with sharing with you what those things are, then you can really listen. Now, not to say there wouldn't be consequences, there probably would be, but that wouldn't be the first response to that. And so what we've done at Mayo Clinic is with physicians who are struggling with this area is help them go through this exercise in which we list their fears and they have conversations with their team and their staff so they can feel open to talking to them. And for the people that felt powerless to have this conversation, then there's a script for them as well to do so. So in the bottom right corner is a QR code that walks you through the steps in the exercise. So thank you, Dr. Hartmark.
Thank you so much, Keith. I'm Dr. Jen Hartmark-Hill. I'm a family medicine physician. I'm at the University of Arizona College of Medicine, Phoenix. And, just wow. I mean, we've all felt that experience of a powerful story in moving us. And what Keith shared is no exception. What we've been hearing all day from people in this session has been really, really amazing. And I think really illustrates that point. Now, there's a reason for that. And that's because We heard earlier, our brains are wired for compassion. Guess what? Our brains are wired for stories, going way back, even before our written language is passed down. Stories were a part of our DNA, and that's really cool. So I'm going to actually, as a physician, as someone who's a medical educator and teaches narrative medicine and health humanities, with the hope and the research behind it, I think that this can help our trainees be even better physicians. I'm really fascinated by the science of why stories are such a special form of communication for creating connection. So to do that, I want to just highlight a research paper that was published by a neuroscience team out of Princeton. And what they found, they did something really cool. So they used a special form of brain imaging called a functional MRI or fMRI that shows brain activity. And they had a storyteller and listeners. And they had the storyteller share an unscripted, real life story with these listeners, and they tracked brain activity. And what they saw was when the listeners were attending and attuning to the story, their brain activity, the way the scans lit up, started to change and started to mimic the brain activity of the storyteller. I thought that was so cool. So I'm really glad to be able to share that with you today. So what they concluded in their study is that when we share stories, when we intentionally use them as a tool in our toolkit, we can get something called neural coupling. And that is a really important thing because in communication, we need that attention. We need to bring people together collaboratively, right? And we have so many distractions. I'm like trying to always put my phone away and listen, right? But when we tell stories, when we hear the experiences of others, that really makes a difference. And, so the other thing is they found was this attunement. So how they described that was so when they looked at the scans, it wasn't just the areas of the brain that lit up that you would expect. So processing what they were hearing, the audio, maybe some visual, imagining, the language, the linguistic parts. They also found that parts of the brain that are important for social processing that's critical to communication. So things that allow us to imagine or do some perspective taking on the beliefs, values, and goals of others. Those parts of the brain were lighting up too. And I think that is really, really cool attunement to one another. And I think all of these things can help build a collaborative environment. So being intentional and sharing our stories really matters. Another thing that some of the more recent studies that have built on this work have been showing changes in brain chemical signaling or neurotransmitters. So just to provide an example of that. Dopamine, I think we've heard about it in a lot of different areas, but enhanced memory or attention, especially when you're telling an emotionally charged story like Keith was doing. If we empathize or resonate with a speaker or even respond with laughter in response to Keith's great sense of humor at various points in his story, we get release of oxytocin. And guess what? That enhances bonding and trust. It's like a short circuit, right? To cohesiveness and bringing people together. And then successful problem solving or resolution gives people a spike of these anti-stress endorphins, which is, I think, it's a nice little gift to give your colleagues. So I think all of those are really important to create this very positive milieu or sense of being in teams. Certainly many other forms of communication can do this, but keep in mind stories. I want to link this to what we do with leadership. What our group is doing under Dr. Stonnington's amazing leadership is we're looking at a number of things. So we have a draft construct that we're examining, and we're looking at things like belonging, respect, authenticity, vulnerability, and empowered empathy. Now, when you think about stories, when you think about sharing stories, your story with someone else, it's a very humanizing thing to do. Within your story comes out your values and what you care about, what matters to you. And I think that just brings us beyond the job title to who we are as a person. And when other people, then we can feel seen and heard as who we are as a person. And we can feel respected in that way. Of course, sharing our stories involves a measure of vulnerability. And when we are in these brave spaces and we are vulnerable, the beauty of that is that invites vulnerability and authenticity in others, that people see that they're safe to do that, they're going to be supported, they're going to be valued for doing that, and we're going to move together in a cohesive way because we know who we are and we know what our purpose is. So stories create this space for sharing our values, and I would say acting in compassion with one another. So that empathy, that knowing the lived experience of somebody else, I like to say that compassion is empathy in action. So when you empathize, you can take it the next, you can act in compassion. A compassionate act might be like, how are you really? Let's sit down, let's talk this through. I'm here. So I want to leave you with a third point, and that is some practical aspects of when we're inviting stories from our team. It's not the most natural thing. It's not what we all were trained to do maybe in our health professions and other training. And then when we're sharing our stories, some things to think about. So there are a number of frameworks I think are really helpful. Some that I'm really using more and more are coaching style questions, because coaching style questions are very person-centered, and they can help bring out the motivations and the strengths of others. And that can be really, really empowering. So I'll put up a couple of example questions. There are many out there, but kind of tell me about a time when. That always invites story, right? And so when we're sharing stories of our own as leaders and as team members, there are some components to consider as well. One of them is coherence. Is there a mission you're working on? Is there a project with a goal? Is there data that you want to share and make sense of with your team? We all have so many stories, whether we think of ourselves as natural storytellers or not. Do you have a story that might align with the values therein? Share that story. That's a good story. That's a relevant and timely story, right? Visual. So you want to trigger kind of the vision centers of the brain as well, so they can see what you see. Kind of like the old adage to writers, like show, don't tell. Same in stories. Help them see what you see. Structured. So stories can be very brief. They can be lengthy, but what they should all have is a beginning, a middle, and an end. And the cool thing about this is this is the creative part. You get to decide where the story starts and where it concludes, and kind of how it aligns, so you can make some adjustments there. And I encourage you, try this out and continue to work on it, see what resonates. And then the last part that you can't see on here is kind of the lesson learned, and that's the aha moment. And we certainly this is also in the neuroscience too, that as people anticipate, where is this going? How is this going to be? This is a big problem. How are we going to fix it? People are very engaged. So sharing that aha moment, that lesson learned within your story, helps kind of bring people along with you to that conclusion and release of endorphins like we talked about earlier. So thank you for your kind attention and letting me share that. With that being said, I'm going to turn things over to talk about some really cool current research in the Brave Spaces arena from Dr. Adame.
Thank you. Carrie, how are we doing on time? Okay. Hi again. So all good stories start with good communication, right? I am a communication professor at Arizona State University, and I am here to talk to you about how a student of mine, Christina Meneses, and I are working on a project with the Brave Spaces team, along with all of us, to try to really understand what are the behaviors that lead to these braver spaces. Huge question, right? And as Dr. Hartmark-Hill mentioned, we have started to conceptualize this in a 5-step process, kind of. And in this specific project, we are honing in on the V, the vulnerability part. So that's what I'm going to talk to you about today. Our research questions are twofold, very broad research questions. And those are, in what ways do healthcare professionals reinforce invulnerability in ways that prohibit brave spaces? And also, in what ways do healthcare professionals destigmatize vulnerability to create brave spaces? We are working, for starters, with the Mayo Clinic, and Christina has been this is her dissertation project. So she's been collecting data. She's worked very closely with Keith over the last several months to collect lots of data. She has 40 hours of observation and has done about 5 interviews, has several more planned. And some of the reasons why well, Mayo worked, but also we want to know specifically what are the people who are doing this well doing? What does this look like when the people who are doing it really well are doing this, right? Like we all have been talking about compassion and this peer support, and we know that there's all sorts of different resources. We want to follow the people who we know are doing this and doing it really well, and then create trainings that we can go, quick little trainings in small little increments that we can go implement in different spaces and try to figure out how we make these changes quickly. If anybody does not have enough time, it's healthcare providers, right? So quick interventions that are not just like a navel gazing, let's just all like spend time on a training just for the sake of training, but really like let's make a change quickly. So this is our study. We are just completing phase 1.2. So we did the qualitative work. We might have to do a little bit more field work after we do some participant member checks, but we're in the phase of participant interviews at this point. Once Christina's finished with her interviews, she will go and look at all the themes, figure out all the information. I have some preliminary themes from her today, and then we will move into creating the training and then testing the training. That's an important part, is testing that training. One reason why, like I said, positive deviance case, we're looking for people who do this well. Some preliminary data that we have. I am not the one with the data. Christina is, and she is not here today. She wishes she could be. But the one I am going to talk about is the open door versus the welcome in. And all of these are like tensions. If you think about, like, often in workplaces, we talk about and think about, like, I have an open door policy, right? Maybe it's not actually written down. Maybe it is. But if you're anything like my students at ASU, an open door policy doesn't always mean people are actually going to come into your office, right? And so Christina, in looking at these positive deviance cases, has found that something that happens in the difference here is that some people are welcoming in, not just saying open door, but welcoming people in. And one of the cases that I want to highlight today is a case that Keith worked really closely with this provider, this physician, in helping her be more vulnerable and create more space for herself to talk to other people. One of the ways that he did that was by coaching her to maybe think about parking in different places every day, so that she had to literally walk through other people's workspaces on her way to her own work. And as she's walking through these workspaces, she's saying, "Hey, how you doing? Hi. Hey, how's the family? Hey, how's this going?" Right? So now she's in their workspaces. And it turns out that that's influencing how other people see her as well. This is a quote from that specific provider. She says, "Yeah, so having done this for a while, I also have an open door policy, and I'm so amazed at the number of people that will stop by and want to tell me something. So they're initiating those interactions. I don't explain it. That is the open door policy. Yeah, no, my door is open if I'm not in a meeting." And I think a combination of that and me walking into their workspace and talking to them when they walk past my office and see I'm in my workspace, why not interact? And so here's one example of how this specific provider has taken what we all think of as an open door and actually welcomed people in, just by taking a little bit of a different way into work each day. I'm sure she's doing a lot of other things as well. So some initial pointers that Christina and I had for welcoming people in, how to welcome people in, is to make yourself seen in other people's workspaces. Maybe that is sitting outside during a lunch hour, or maybe it is taking a different route to your own work. Maybe it's taking your sitting outside instead of sitting in your office, or getting coffee at a different place every day. And also telling and retelling stories. This is an important part. Telling and retelling stories that emphasize the good things that happen when people speak up. And you can make these stories up. They don't have to actually be real. But just don't tell them that, right? But you can, if you tell and retell stories that, hey, did I ever tell you about the time when someone told me, like Keith is doing, right? Somebody told me I had kind of messed up, or I had a friend who told me they were really struggling. And then all of a sudden we were just like, every week we would go on a walk and talk about this. And so creating stories that create space and exemplify that bravery is welcomed in the workplace, especially in the context of vulnerability, can help move us toward that way as well. We're going to test it. So we will know hopefully next year what the differences are between the control and treatment groups when we do test the training. But that is, and also, if you do know, or if you are a person who is a positive deviance case, which sounds weird, but it means that you're really good at creating these spaces at work, or maybe you know someone who is, please do contact us and let us know, because we do want to have a bigger, broader impact than just at Mayo, and we want to start to implement those other stories. So thank you very much for your time today. We're excited to answer any questions that you might have, and thank you all for having us.